Good morning. Welcome and thank you for joining us for our Northern Light Health, Good Health is Good Business Zoom conference. Our Northern Light Health team wishes you a healthy, happy new year. Today, we will be navigating the challenges of pharmaceutical costs. Recognizing that pharmaceutical costs are taking ever larger bite of your healthcare dollar, we will look at cost-saving strategies, benefits design, new and expensive drugs on the market, including the high-demand weight loss medications. Finally, we'll lay out what consumers should know. Once again, we have a lot of territory to cover, so here we go. Our panelists today are Connor Kennedy, account executive with Acadia Benefits; Michela Fiore, a doctor of pharmacy who serves as ambulatory clinical pharmacist specialist at Northern Light Health and as associate clinical professor and director of continuing education, program planning, and communications at the University of New England; Matt Marston, a doctor of pharmacy who serves as vice president and chief pharmacy officer at Northern Light Health. I'm Dr. Ed Gilkey, senior physician executive at Northern Light Health. I'll be your moderator for the next hour. Before we get started, I will read our legal disclosure. The information presented in this session is provided for educational purposes only and is not meant to substitute professional or medical judgment. Northern Light Health does not know the particulars of your situation, so the information presented today is intended to be general in nature and may not apply to every individual situation. Northern Light Health and the presenters make no guarantees or warranties regarding any information provided. A reminder, this hour is for you. If at any time you have a question for our panelists, please use the Q&A function. I'll keep track of your questions and have our speakers respond. Also, I hope each of you will take a few minutes immediately following this hour to answer our quick 5-question survey. Your input directly affects our topics and helps guide our future conferences. Our first speaker is Connor Kennedy, who will speak about benefits design as it relates to pharmaceuticals, with strategies employers can consider using to target this growing expense. Connor?
Great. Thank you very much, Ed. So I'll start by talking off about plan design as it relates to pharmaceuticals in the small group market. These are fully insured small group plans. So small employers, we consider them, any company that's under 50 employees. When you're under 50 employees and you're buying a group health plan, it's highly controlled by the state medical carriers. So carriers in the small group market control the drug benefits for their medical products and change their plan design every year. If you've had a plan for a few years now in the small group market, you'll notice every year they change deductible or out-of-pocket maximum or co-insurance or co-pays. And then, of course, they always change up your drug benefit. In the small group market, it's a 5-tier pharmacy structure, which allows the carriers to choose how they will share the cost with members for different drugs. Now, this applies to everything besides, under the Affordable Care Act, certain preventive drugs are covered at 100%. As a reminder, preventive medications, they're used to prevent conditions from developing or prevent conditions from coming back. So when we're talking about the 5-tier structure in the small group market, the first 3 tiers are most commonly subject to a copayment. So depending on what plan you choose, it could be a 5, 25, 50, or a 25, 50, $100 copayment for those drugs. And those are your preferred generics, the non-preferred generics, and the preferred brand name drugs. Now, when we move up into tiers 4 and 5, these are where the drugs become much more expensive, most commonly subject to additional member cost sharing. So for example, it's a copayment after you've met your deductible, or co-insurance after you've met your deductible. As a reminder, co-insurance, right? That's just the percentage, the cost share with the insurance carrier. It could be at about 30%, right? So you pay 30% of the cost of that drug after you've met your deductible. Or co-insurance up to a script max. Again, sharing the cost of that drug to a script max of, say, $500 or $600. These are your non-preferred brand name drugs, and your preferred specialty medications. Now, plan design as it relates to pharmaceuticals in the large group market, again, talking specifically in the fully insured market, we consider large employers over 50 employees because that's when you become experience rated. Your renewals are based off of the health of your population. So in the large group market, employers have much more flexibility in choosing a prescription drug benefit. Many more plan designs are available. For example, a specific co-payment amount for each tier. So you don't have to do the cost sharing, just say a 10, 30, $50 co-payment. A specific RX deductible. So for example, trying to keep premiums down, you have members meet a $100 or $500 pharmacy deductible before they start paying co-payments. Or of course, co-insurance after your deductible, et cetera. Again, a lot more flexibility in the large group market. Medical carriers will offer different tiering structures in the large group market as well, as opposed to small group where it's just that 5 tier most commonly. In the large group market, we have the 3 tier, 4 tier, and 5 tier pharmacy benefit options. Medical carriers will offer alternate drug formularies to choose from as well. So drug coverage will differ between each formulary offered, resulting in higher or lower premiums. So for example, you could choose a value formulary as opposed to a premium formulary. The premium formulary will cover more drugs than the value formulary does, resulting in higher or lower premiums. Talking specifically about high deductible health plans, right? These are the plans that can be paired with a health savings account. For large and small employers, members must meet their deductible before the medical plan starts sharing the cost through coinsurance and or copays. One exception, again, are drugs included in the preventive drug benefit list, and your deductible is waived for preventive drugs. So a few pros and cons of high copay plans. The pros, it helps reduce plan premium by shifting out-of-pocket costs to the member, right? It's just a give and take there. A higher copays, the insurance companies don't have to pay as much for those drugs. Increased drug cost transparency for members. Members can start to see that the drugs in the higher tiers are going to cost a whole lot more for their high copay plans. Maybe they choose a different type that falls into a lower tier. Engages members to consider lower cost plan options. So if you're trying to move a certain population to a lower cost plan option, if you say you offer 3 plans, maybe the top 2 plans have higher copays for certain drug benefits. Cons could pose a barrier for employees receiving care. These copays could become very expensive. And also a con is the pharmaceutical copay reimbursement programs can offset the value of a high copay plan. I'm talking specifically about extremely expensive drugs here, where a pharmaceutical company will actually pay the member's deductible or out-of-pocket costs for that member to continue taking the drug that's working best for them. So employer strategies, if I'm talking about the small group market, again, under 50 employees, in the regulated small employer market, employers really must accept medical carriers' plan designs and the drug formularies. Right? It's very rigid. You have your opportunity to select between carriers, but very rigid plan design. There are plan design options, but no cost control strategies are really available to the employer. In the large group market over 50 employees, large insured employers can select medical carriers based on capabilities. So leading up to your renewal, of course, you can do an RFP and explore other carrier options. Maybe a carrier has a better wellness program that's targeted to bringing down certain prescription drugs. Every major medical carrier has a pharmacy benefit manager or a PBM, a partner to manage drug cost. Employers with high drug utilization can add specific RX deductibles to help control cost as well, like I talked about before. Now, when you're a large self-funded employer, you have lots of options available to you. I've been talking all about fully insured groups because that's a majority of the policies here in the state of Maine. But very large self-funded employers have basically the whole book open to them. They can carve out their PBM or their pharmacy benefit manager. They can create custom prior authorization and prior pre-certification as well. They can set up gene therapy risk pools, et cetera. So there's lots of different options for large self-funded employers when trying to manage pharmacy costs. The last strategy I kind of wanted to touch on here is something we've been seeing our larger customers take advantage of when they're really trying to control the cost of a certain population within their company. So the individual coverage health reimbursement arrangement, or you've probably heard of it as an ICHRA. It's available for any size employer, but really large employers over 50 are able to take advantage of this program because large employers are experience rated, right? So you're rated on the health of your population. So an ICHRA allows employers to use an HRA to reimburse employees for qualified individual medical coverage premiums. So employers may offer to a group health plan to segments of the population who are not offered the ICHRA. So for example, the ICHRA program has saved employers dollars by moving the claim risk back into the individual marketplace. So if you have a population that's say outside of the state of Maine, and you can see that they're really driving claim costs for your plan, businesses have the ability to choose eligibility requirements based on employee class. So full-time, part-time, salaried, seasonal, temporary employees, and employees with different locations. So where we've seen companies successfully use the ICHRA is by removing a certain population from the group health plan, implementing an ICHRA, reimbursing those premiums. They're still pre-tax for the employee. And basically that takes that poor risk out of your experience and moves them into the individual marketplace. And when you look at your next year's renewal, you will benefit from removing, say, a high prescription drug from your fully insured plan.
Well, thanks, Connor. Next up is Michaela Fiore, who will speak about navigating pharmaceutical costs, cost-saving strategies, new drugs, and what consumers need to know. Michaela?
Thanks so much, Dr. Gilkey. It's a pleasure to be here today. And as Dr. Gilkey said, I'm here to share with you all some tips for how to help your employees and yourselves to save money on the cost of prescription medications. And I think it's a nice segue from the great information that Connor just outlined for us. So for today, my goals and objectives for this portion of the session are really just to equip all of you with the knowledge and the tools to help you take control of the high prices associated with medications. Also to provide some practical and actionable strategies to help you to save money on prescription medications, in particular by leveraging patient assistance programs and the available discount options that are out there. And then in general, just to foster a sense of advocacy for you all. A big takeaway message from my portion of today's presentation is that it's so important to actively engage with healthcare providers, insurance plans, and available resources to find the most effective solutions for prescription medication use. So to begin, as a brief introduction, I think it goes without being said that prescription prices have been steadily rising in the United States, with more than 4,200 medications incurring average price increases of 15.2% between January of 22 and 23. So this is a big problem for a lot of people. First and foremost, the patients who need the medications, but it also presents major challenges to healthcare payers and employers. So finding ways to effectively manage prescription drug costs is especially important in order to facilitate patient medication adherence to necessary medications. So when we think about prescription medication costs, it's important to have some background on the factors that contribute to high costs. Some of those things include research and development costs, marketing and regulatory expenses. And unfortunately, those factors can make some medications extremely costly and outright unaffordable for patients. Insurances help, and we will talk a little bit about insurances in a moment, but insurance copays can be high and difficult to afford. And insurance deductibles can also be quite high, meaning that the individual is paying out of pocket for the medication throughout most of the year until such time that the deductible is met. And in some cases, it never is. To start, I want to emphasize some points about generic medications and formulary. So generic medications are indeed bioequivalent to brand name medications, and that's important to understand. So this can sometimes cause some discomfort among patients. I know in my clinical practice, sometimes patients will think that even if they're getting if they're getting a generic medication, they think they're not getting the best version of the medication, and that is not the case. Generics are bioequivalent to the brand name alternatives. And the big takeaway is that the generics are much more affordable due to lower development costs. And in some cases, that can save the individual as much as 85% on the medication when compared to the cost of that brand name equivalent. So I would encourage everyone to talk to their healthcare provider about using generics wherever possible to help save as much money as possible. And then the next thing to think about is the formulary. So insurance formularies are basically just a list of all medications which are covered under the insurance plan. And furthermore, that formulary will outline which medications are covered at which cost tier. And we'll talk more about what that means shortly. Generally speaking, tiers 1 and 2 medications are going to be less expensive than tiers 3, 4, and 5. So here's the insurance tier structure explained in brief. As mentioned previously, tiers 1 and 2 are typically going to be the lowest cost to the patient, and that's because these tiers include the insurance's preferred generic drugs, as well as some of the non-preferred generic drugs. Now, when we get into tiers 3, 4, and 5, this is where we see the preferred brand drugs. But as we talked about earlier, those branded drugs are typically going to be quite expensive. So although the term preferred sounds good in theory, these medications can still be associated with very high copays for the patient, depending on how much the insurance plan will cover. Tier 5 is the tier that's going to include your specialty drugs, both brand and generic. And specialty medications are the ones we use to treat conditions like rheumatoid arthritis, psoriatic arthritis, Crohn's disease, hepatitis. Those are very, very high cost medications in the several thousands of dollar range. So with that background, let's transition into talking a little bit about the prescription assistance options that are out there to help people afford medications, coupons, and some of the discount services that can be utilized and that you can educate your employees about. The first thing to be aware of is that pharmacies often have their own discount medication lists for common generic medications. Okay, so oftentimes they call these the discount drug list or maybe the $4 list. These exist in many of the big chain pharmacies as well as smaller pharmacies. And they, the smaller pharmacies often have their own versions of these types of programs. Some pharmacies even offer price matching policies. So it's really important to advocate and shop around when you're looking for a pharmacy to fill your prescriptions. The first assistance option that I'd like to introduce is called Needy Meds. And this is a great website. It's free. You don't need an account. You can just go to their website, find assistance with the cost of medications. And you can look up the medication by name on their website, and it will provide you with direct links to patient assistance programs, coupons, support services, and even drug information literature as well. Patient assistance programs are specifically designed to help people get their medications at low or no cost to them based on qualifications that they must meet for to be eligible for the assistance. So this is a great starting place to get linked up with a lot of really helpful and highly useful information. Here's an example of a coupon from Needy Meds. So these coupons, anyone can print them off and use them by simply going to needymeds.org. And these can save up to 80% on the cost of prescription medications, but they're only to be used by themselves. They're not to be used in combination with insurance. And so, in the case of a medication that isn't covered by the insurance or there's a very high plan deductible, this is going to be a great option. Or maybe by using this discount card, the price of the drug is actually lower than the copay cost would be with the insurance. I've definitely seen this happen in clinical practice. So the discount card is really nice in those situations. Doesn't expire, and it can be used as often as needed without any fees or registration required. Another option is GoodRx, which some of you may be familiar with. This is another website where you can go to download free coupons. The cool thing about GoodRx is that it allows the user to search for the drug prices and discounts by pharmacy, because the drug prices will vary based on what pharmacy you look at. This is similar to the Needy Meds discount card in that it's not insurance, and it must be used in place of insurance to help individuals to pay less than the cash price for medications. So I wanted to share a quick example of what this would look like if you search for a medication on GoodRx's website. So I searched for a diabetes medication called Invokana, which is quite expensive. It can cost in the range of thousands of dollars. You can see how the price is significantly lower and varies depending on which pharmacy you look at. So as I mentioned earlier, it is so important to shop around when looking for the lowest price options. Another resource that I wanted to introduce is a newer one. It's called Mark Cuban's Cost Plus Drug Company. Some of you may recognize the name Mark Cuban from Shark Tank. He's a millionaire investor, and he started up his own pharmacy where he was able to start offering certain generic medications at cost with a small markup. And that markup covers their pharmacy labor and their shipping fees. This is a new option, as I said, but I have seen some of the providers I work with using this option to help patients get better prices on their medications. It's super simple to use. The patient would just need to ask their provider to send a prescription to this pharmacy, and there's an easy form on their website to download and use for that purpose. So the first step would be talking to your healthcare provider to see if a generic is an option for you, and then you could take a look on the Cost Plus website to see if they carry that medication. Here's a quick snapshot from the Cost Plus website that shows a few medication examples. So you can see the prices are substantially lower for some of these, really high cost medications, some specialty medications. Invokana, that one that I used as an example, is on here as well. So you can see the difference in price. Now, I went over to the Cost Plus website and I used that same medication, Invokana, which I used in the GoodRx example previously. And I did that to illustrate the price difference. So you can see that the same strength and day supply and quantity is several $100s cheaper here. So really an interesting option that's out there and something to keep in mind. Lastly, I want to mention manufacturer savings programs. The manufacturers often have their own savings cards and coupons available for free access on their website. And in this case, you do need to have commercial insurance to use these savings, but they can be really helpful in covering the out-of-pocket costs. And in addition, they often have patient support services to link people up with resources that help them with certain things like understanding their insurance coverage or getting access to financial assistance or getting their medication questions answered. So it's a really great service. I will also say, as a pharmacist, I would add that pharmacists are a very accessible resource for having medication questions answered as well. So please reach out to your pharmacist if you ever have any questions. Some manufacturers also offer free trials of medications as well, which can be helpful. And I wanted to mention that because especially in the interim period, when a person is just starting out on a medication, these free trials can be helpful. That way, the person has time to see if the medication is going to work well for them. They can try it out, see if they tolerate it well without significant side effects that impact their quality of life. And then if it does work well for them, they can move forward with a savings program or a patient assistance program as applicable. So to summarize, the key takeaways for navigating high medication costs that I mentioned today, first and foremost, always want to emphasize, inquire about generic alternatives for prescription medications, which are oftentimes much more affordable. You also want to explore those pharmaceutical companies and the other assistance programs that are provided out there, the discounts that we talked about, free medications, those types of things based on financial need are often offered to people when they seek those prescription assistance programs. So definitely want to look into those. Compare prices with different pharmacies. As we saw today, that does make a big difference. looking for those free samples and trial offers for the temporary cost offset to ensure that the medication is going to work well for you. And then lastly, just really understanding your insurance coverage, including your copays, your deductibles, and discussing alternative covered medications with your provider are all really helpful and useful pieces to making sure you get the best prices possible.
Thank you, Michaela. Our next speaker is Matt Marston, who will speak about weight loss drugs and obesity, ROI, risks and benefits, and where the market is heading. Take it away, Matt.
Great. Thank you very much, Dr. Gilkey. And as Dr. Fiore mentioned in her great talk that she just gave about the expense of medications, there's no greater example in the recent year than the rise of GLP-1 medications as a category, as a recent advancement in medication-assisted weight loss. Many of you have probably heard of and are familiar with Ozempic. There's been a big marketing blitz about that. Additionally, many celebrities have come out in the media speaking about their own personal experience, including Oprah Winfrey, Elon Musk, and other really notable names. So this is certainly a hot topic and one that many employers are grappling with around the country in discussing how they could deal with the very significant cost of these drug therapies. So why is weight loss so significant, and why are these drugs taking off the way they are? Currently in the United States, more than 2 in 5 adults meet the classification of being considered obese, which is considered a BMI greater than 30. And that outpaces the global average. In particular, we see that those more well-off countries have higher rates of obesity, and globally 39% of the population is considered obese. The World Health Organization also predicts that this is going to be a rising issue, with 51% of the global population being considered obese by year 2035 at current growth rates, which you can see in the graph to the right from the World Obesity Atlas, which is a leading report that comes out every year about the epidemic of obesity, which now really is considered a pandemic where it's rising across the globe. The estimated total cost of illness related to obesity is also expected to rise to around $4 trillion per year. And I'll talk a little bit more about some of the economics of that in later slides here in this presentation. But this represents more than the total cost of healthcare of COVID-19 in 2020 when it first came out. And you can think about all of the mass vaccination clinics, all of the alternate care sites that needed to be developed for all of the bed capacity issues that were as a result of people flooding in through our hospitals. So really, we're talking about significant cost. Now, what's also relevant in this discussion is considering the history of weight loss medications. And while they're very prevalent in the news today, and they've certainly been into the limelight, this is not a new thing that we're experiencing now. In fact, for hundreds of years, you think back to the times of the Romans, tactics to lose weight were implemented, such as patients that would vomit, or not patients, but rather Romans would vomit after eating large amounts of food in an effort to curb weight gain associated with those meals. Right, so that was one tactic that was implemented. But in the recent years, from the 1900s on, this is where we really have the advent of clinical trial-based research into anti-obesity medications. One of the first of which was high doses of thyroid hormone, which does produce significant weight loss, but later it was determined to have significant adverse cardiac outcomes, increasing risk of heart attack and stroke for people that would take high doses of thyroid hormone, which has since fallen off. And then you can see around the World War II era, the rise of amphetamines, which are actually derivatives of methamphetamine, which is a common street drug that you see out there these days. And what was noted was when people took these in the military to stay up and increase performance on the battlefield, they also lost significant amounts of weight. And the rainbow pill period, as referenced here, is when they combined amphetamines with other medications that curbed appetite and had other effects that produced weight loss. What they saw with this is, particularly with amphetamines, there's a high risk of abuse, and addiction became a major issue with amphetamines. And then when combined with other products, the dangers of adverse cardiac outcomes with these medications also increased in a corresponding rate. So anorectics and antidepressants, as well as some of the other categories listed here, there is a sordid history throughout time here of weight loss medications coming out, producing good effects in patients losing weight, but later finding really significant adverse effects that came later downstream from the clinical trials, including things like those adverse cardiac outcomes, stroke, and additionally cancer for the leptin-based drugs. So now what about this new category of medications that's in the limelight, which are considered GLP-1 medications? And the big question that we have here is, have we really reached a turning point where we have highly effective medications for weight loss that are safe? And that's the big question that's out there right now, because these medications have been used for some years now for the treatment of diabetes with very profound effects. In fact, they're considered category 1 first-line agents for those ahead of when they might be eligible for insulin, because they reduce hemoglobin A1C, which is a measure of blood glucose control, quite significantly. And they also produce significant weight loss, which also improves insulin resistance. So how do these medications work for weight loss specifically? They work in several different areas, one being the brain. It suppresses appetite and it increases satiety, or that feeling of fullness after you eat a meal. Also in the stomach, it slows down contractions of the stomach, which also makes you feel full, and it decreases the effects of physical hunger, allowing you to go longer time periods between meals and snacks. It directly improves sugar management hormones within the pancreas that are released, as well as decreasing blood sugar and blood glucose production overall. And then it also decreases the production of fat. So multimodal effects across many different domains that all produce weight loss. And that's why we see such great effectiveness from these medications. And you can see in the table to the right, there's really been an explosion of new medications in this category. And there's more that are in the pipeline to come out. In fact, there's another product that didn't even make it into this table, which I accessed a few days ago, which is Zepbound, which is another agent that just hit the market for weight loss. So we're going to see more of these coming. So speaking about the effectiveness of these medications, this is direct from clinical trial data, and you can see really the profound effect that these agents, semaglutide, for example, or Ozempic, has in this chart to the left. You can see the separation of these curves here. The light gray represents placebo versus the dark blue, which is the semaglutide itself. And patients that took these medications saw quite significant reductions in their body weight from baseline. Some of these patients, you can see that a median or an average weight loss of around 15.2% change from baseline in those participants at week 104 from taking the medication. One thing that's come to light recently in discussion about these drugs, though, is that you have to take them indefinitely or the weight will come back. So the effects of the drug in increasing that feeling of fullness and weight reduction will go away if you stop taking the medication. So this truly does become a maintenance medication, or one that's taken long term. Some common side effects that patients report for this, these are expected. They have such a high frequency, is nausea, vomiting, and diarrhea. So those GI side effects from these medications are quite pronounced. That's why you have to start at a low dose, and why that low dose needs to increase over time in order for you to have the effect, but be able to tolerate the medication itself. Some rare but serious effects, pancreatitis, and I actually know of a patient that experienced this quite significantly and landed in the emergency department. Very rare, though. Most patients do not experience this, but that's one that I would say is probably more significant than the rest on this list in terms of frequency. Medullary thyroid cancer, there's a warning on this medication for this, although there's some arguments out there about the significance of this risk because we're truly not seeing many of these cases at all above the prevalence of the general population now that many people have started taking these drugs. And kidney injury, which is also extremely rare and more common in those that are predisposed to that. One thing I want to note before we talk about the economics of this category of medications is the extreme cost. So you can see up in the United States how significant these are, with Wegovy topping the charts of around $1,300 per month every time a patient fills these medications. And then you look at other developed countries and you can see the significant delta between what we pay in the US versus other parts of the world. And so this is one thing that both insurers and our patients and communities are grappling with, is that the cost of these medications is significant and it far outpaces what we see in the rest of the world for this drug category. So what does that mean, right, in a global context for our country specifically in terms of healthcare spend and potential impact of these drugs? There's around 70 million adults in the US that are considered obese. And as mentioned, the average retail price of a 1-month supply of Wegovy is around $1.3 thousand. If everyone in the US that was categorized as obese were to take a GLP-1 drug, that would translate into $1.2 trillion in cost. And to put that into context, our spend as a country in total for all healthcare in 2021 was $4.2 trillion. So with GLP-1 agonists representing a potential market of around 1.2 trillion, that's a significant rise in healthcare spend that's anticipated. Now, what about the downstream effects of obesity? We know that it increases your risk of heart attack and stroke and a number of other adverse outcomes. If we look at obesity-related healthcare spend, including things like hip replacements, knee replacements that occur at a higher rate with obesity, we can attribute around $0.2 trillion of healthcare spend to obesity-related healthcare expense. Now, looking at actual dollars in 2022, as a country, we spent $3 billion, and projecting that growth curve out to 2028, that should rise up to around $16 billion. It is noteworthy to think about some of the other things that are going to happen as related to these medications, such as reduced need for orthopedic surgery, hips and knees. Those replacements could go down as obesity rates go down. It could also result in lower incidence of diabetes and hypertension, which are significant benefits, and it can prolong life expectancy. As we know, those that with obesity have shorter lifespans. So there are benefits associated with this for sure. And I think that one major component that people are grappling with is other modalities like bariatric surgery, which is a one-time significant expense that does not continue lifelong, have a significant cost benefit as compared to these with the pricing that the way it is in the United States. So some unintended challenges or consequences of our current price point and where we're at as a country with these GLP-1 medications. I'll list a couple headlines here for everyone's review that have occurred recently. So Ozempic prescriptions could be easy to get online. Its popularity for weight loss is hurting those who need it most. So this created significant buzz in the media where drug shortages have really reached a pinnacle in the US, not just with this category of medications, but others as well. And one of the things that our country has been grappling with this is that as people have scrambled to get a hold of these medications for weight loss, it's resulted in a shortage that's impacted those that were previously taking it for diabetes. And this led to other unintended consequences. Recently, the FDA stated that it has seized thousands of units of counterfeit Ozempic. And you could just go on Facebook and see a number of ads related to this, where there's doctors' offices, pharmacies that are compounding Ozempic or making it in a lab type format, which which is not actual Ozempic, and the FDA is now cracking down on those. And with a recent example on the next one, ACA Pharmacy out in Nashville made millions of dollars selling an Ozempic knockoff. They were recently shut down by the FDA. And then on January 16th, just 2 days ago, the owner of that pharmacy was found dead by suicide. So the costs associated with these medications and also the severe demand for these medications is really gripping our nation. And it's something that as employers, we're going to have to tackle. And as a country, we're going to have to address the need for weight loss with the rising cost of our available agents.
Well, thanks, Matt. Great information. All our speakers are invited back on video to answer questions. Matt, this first one is for you. We'll stay with the weight loss drugs for a moment. Are the current weight loss drugs different and better than the older weight loss drugs? And I'm kind of reflecting, I guess, back on the one slide where you're showing us chronologically what happened over time. Maybe you can give comments on that.
Yeah, so it remains to be determined because, as I mentioned, several of the weight loss medications showed great promise in clinical trials, and then later were discovered to have long-term adverse effects that sort of outweighed their usefulness. But there's a lot of excitement about these drugs because we have experience with them in diabetic patients, and we have not seen long-term significant adverse outcomes with those that took those medications to control their diabetes. In fact, we're seeing the opposite. We're seeing really great outcomes of taking that medication. And so that offers a lot of promise. Now, one of the things that we always have to take caution on, though, when we in healthcare look at these clinical trials, is that the diabetic population is much smaller in size and scope than the obese population. And so if you expand out to a much larger population in terms of numbers across the country, we're bound to see some of the more rare side effects come to light that maybe we weren't expecting. So that's one of the words of caution that we often use in pharmacy is that, you can't just take one indication like diabetes and extrapolate that to another one like obesity, because they don't necessarily respond in the same way across much larger groups of people.
Great. Well, thanks. I have a follow-up question for you, Matt. And, thinking about the information coming out, we recognize you had pointed out that using these medications to lose weight and to maintain that loss requires, indefinite use of the drug. We're also learning that they do a great job helping people lose about 15 to 20% of their weight, but then it plateaus because there's metabolic adjustments that go on in the body, you know. So comment on that for a long-term strategy, what that's going to be in terms of costs, et cetera.
Yeah. So one of the things that I had reflected out on that $1.2 trillion in healthcare spend is associated with just that. This isn't the same as some other common strategies like weight loss surgery, where, yeah, it may cost $20,000 to give the surgery, which is a significant expense, but you're expected to have prolonged weight loss associated with that can be maintained indefinitely without ongoing expense. So that's what makes this category of drugs fundamentally different from some of those other strategies that we've seen in the past, and why the cost is so much more significant, because it compounds that as more people get on and start taking these medications indefinitely, you see that significant rise in healthcare spend associated with that. And the significant difference between our spend as a country and others in the rest of the world, which gets a lot of discussion in the media and other sources like our federal legislature right now, is a big contributor to that too. Why we're paying $1,300, while another country is paying $100 a month, is another thing that we have to grapple with as an issue here in this country.
Yeah, it really seems like we're covering the R&D, research and development of these drugs in this country. Yeah. You mentioned bariatric surgery, so I'll just kind of grab onto that quick. Traditionally bariatric surgery, like you said, is like $25,000, and all the issues that go along with having surgery. And it is major surgery, even though it can be done laparoscopically and in and out pretty quickly for patients with a good recovery time. Having said that, though, What's your thoughts in terms of bariatric surgery as a viable approach, considering these drugs, but the lifetime commitment to these drugs?
Yeah, so my thought with that is that that's a leading reason why we have not seen across our country and locally a big uptake among payers of weight loss medications. So right now, less than half of all insurers cover weight loss medications with these new indications. Reason being the economics that I presented, right? So as a health insurer, uh, you recognize that someone's going to be on these long term, it's going to be a lifelong expense that's quite significant versus other modalities like bariatric surgery, which are a fraction of the cost long term. And we haven't seen really anything come to light in terms of long term health outcomes where these are so new and being used specifically for weight loss. I think what we're going to see in the future, though, is more data comes out about the effectiveness of these medications for weight loss and the downstream improvements that you see in patients that lose weight and the economics of those benefits. And hopefully the price come down on these medications to a reasonable level. I struggle to see a future that if we don't see long-term adverse effects of these medications, they don't settle out and find a place in therapy. It's just right now we have not found the price point and we don't have the health outcomes data long term to really prove their usefulness within the weight loss category, which is what the health insurers are looking for.
Excellent. Well, thanks so much, Matt. Kind of this next couple of questions are for you. Starting off with what determines whether a generic is preferred or non-preferred?
So often two brand name drugs help treat the same problem, but one has been shown to be more, I guess, cost or medically effective than the other. Um, so the more effective drug becomes the preferred drug, and the other becomes the non-preferred drug. And these decisions are determined whether the medication is preferred or non-preferred. Are made by an independent group of physicians. For example, the carrier's independent PBMs.
Mhm. So it sounds like it's clinically driven with some modification from a business perspective in terms of cost structure.
Yeah, I'd say that's correct.
Okay, great,
I would
great.
say the carriers lean on their PBMs to kind of shape their formulas.
Mhm. So Connie, you answered one of our participants' questions in the Q&A, but I'm not so sure everyone gets to see that. So I'll ask our team, Karen in particular, if we could make sure that the site that Connor shared gets in the chat so everybody could see that. But I'll ask this question of you, Connor, to just make sure everybody hears about it. So what are some examples of preventative drugs that are covered by the ACA? And you gave a great answer with 100% coverage, and here's the list that you could work off. But you can give an idea of that for our participants.
Yeah, so this is like aspirin medication. I mean, of course, vaccines, tobacco cessation products, and diabetes prevention medicines, things of that nature. And you know, I would refer to the website that I had posted, but also I
Mhm.
would check with your whatever carrier that you're currently have coverage through. All the carrier websites, I always strongly push. If you're looking for information, go to your specific carrier website. That's where they've pushed the most dollars in, and is really providing all the information that you need, and whatever specific carrier that you're currently enrolled with.
Yeah, I think that's really important because even though the ACA, which is a federal approach to, managing healthcare, even though they say a plan needs to cover 100% preventative drugs, that doesn't apply to all plans, as it turns out. There's some exceptions. So I think going back to your plan in particular is very important. And we just shared the site that Connor was talking about. So that's very helpful. Um, Michaela, I'm going to switch gears and get a question here for you. Oh, so you actually answered that question about, where does the savings come from on the good RX and needy meds? I mean, that's a little bit confusing. Maybe you can speak to that just a little bit more here. Um,
Sure.
but it seems like, where does that money come from? Whose pocket does it come from? So,
Yeah, so just as a background again, so GoodRx is basically just that list of prices at participating pharmacies, so the consumer can go through and really compare prices to find that lowest cost. And where that stems from, basically, they have negotiated those discounted prices with each of those individual pharmacies, and then they compile that that coupon or that discount card to present. The patient just brings that in and presents that to access those lower drug prices. So the savings come from those negotiated discounts that GoodRx has established with that network of pharmacies. And then, so GoodRx really what they do, they make their money by pulling in fees through the PBMs. So the PBM is like that middleman in that drug supply chain. And they negotiate prices with the manufacturers on behalf of the insurance company. And so I put a little example there in the chat as well about that, but that's kind of how that works.
so I have a couple of questions related to the programs you discussed, one being the Mark Cuban Cost Plus. So that seems to be the cheapest retail price available. Could an employer use that company for its drug coverage?
So they wouldn't be able to use it for their drug coverage because they don't have access to all medications available. So they only have generics available, and they only have a specific list of generic options. That list continues to grow. I mean, I was actually talking to a physician about this yesterday who said they have used Cost Plus for some patients, and they even said, every time I go back to that website, they have added more medications to their formulary list. So it does continue to grow. However, they wouldn't be able to an employer wouldn't be able to use it for all drug coverage for that reason, because it does not include all medications.
Mm-hmm. Yeah, that actually makes some sense. Then talking about those manufacturer savings program and even the free trial offers, could an employer lower their costs by facilitating employees to use these programs?
So the employer themselves would not necessarily lower their cost by facilitating their employers to use the savings programs, but they still, because the employees will still need to have insurance coverage in order to use the manufacturer savings programs and things like that. So the employer would still need to provide the comprehensive coverage for the employee, but rather these savings suggestions could help to offset the cost to the employee so that they can continue to use the medications they need at more affordable prices.
Mm-hmm. So let me just follow that up quick. When you think about those free trial offers, that's really by design, sort of like in the doctor's office samples to get it started, see if it works. Does the patient tolerate it? Does it actually have the effect you're looking for, like lowering blood pressure? Would it be reasonable to educate your employees through HR about the availability of things like that?
I mean, I don't think it's a bad idea. I think so. One thing that I will say is that depending on where you are working, like I know in the healthcare setting, for instance, we don't allow in my specific site, we don't allow like the free trials for people out of our practice. So like we would not dispense that card to a patient in the practice. They would have to get that elsewhere. And so I guess for that reason, I mean, just like the theme of my content was really to educate and make you all aware of those things so that you can seek them on your own, because it isn't something that you would be able to necessarily get from your doctor's office. So yeah, I mean, I think making everybody aware of these options, in particular with the free trials, in particular for people, like I mentioned earlier, who are maybe new to a medication, not sure how it's going to work out for them, and it's a very expensive medication. I think that that's a good option to explore how they're going to tolerate it first.
Mm-hmm. Okay, well, thanks. Kana, a couple of questions I have for you. You mentioned the concept of gene therapy and associated risk pool. What in the world is gene therapy?
Sure. I guess at a very high level, gene therapy is a technique that modifies a person's genes to treat or cure a disease. But that's not my area of expertise of what exactly it is. But what an associated risk pool would mean for a self-funded employer. Um, Different stop loss programs, and again, this is getting a little bit in the weeds. And just as a note, most plans in Maine are fully insured, but there are large self-funded programs. So there's different stop loss programs that will allow plans to buy into these risk pools so that gene therapy claims will not affect a company's stop loss or claims experience at renewal. Right? These are multi-million-dollar treatments, so they can really
Yeah.
drive a plan into the ground. It's a per employee per month charge to pay for this, and it helps protect the plan from possible future claims.
So I think that's important takeaway for our audience. A company like yours, Acadia Benefits, you have a certain amount of expertise in there to understand the stop loss and reinsurance products that are out there to help with this. You know, I'll just caution our audience, gene therapy is moving down the lines of great individualized or precision medicine where the drug can really target things that formerly people would suffer from or die from early. But these drugs are exceedingly expensive, as much as like $500,000 for a single dose. I mean, maybe I'm even underestimating it. And the pipeline is pretty rich in that. So we are going to see clinically some major advances over the next decade thanks to these drugs. But when we plan for our benefits design, we definitely need to be talking about gene therapy and the costs and how to mitigate those costs while still helping people in a very appropriate way clinically. So I think we could probably do a seminar on gene therapy at some future date. So thanks for that, Connor.
Yep.
I have a question for you, Matt. Can you speak to the effectiveness of Kissimmee for weight loss? I believe it's much more cost effective, but on a risk reduction program due to possible birth defects. Do you have any insight on that?
Yeah, the risk reduction program on birth effects is certainly relevant. Of note, there is a recommendation, particularly when used with weight loss and GLP-1 medications, that there are some risk of birth defects with GLP-1 medications as well. So that's a consideration for these new ones. So I want to note that. But one of the primary reasons why I think we haven't seen Qsivia take off is many of you may remember a weight loss drug that came to market called Fen-Phen, which got a reputation for being pulled from the market due to valvular heart disease, which was a adverse, unexpected outcome associated with that medication. That was thought to be related to the fenfluramine component. It was a combination of fenfluramine and phentermine that made up Fen-Phen. Now, Qsivia is made up of topiramate and phentermine, the drug that they thought was not related to valvular heart disease. So there's a bit of a reputation, I think, that has followed phentermine associated with that. Additionally, phentermine is a derivative of amphetamines, which, as mentioned, have their own issues associated with them, one being addiction. And as such, Qsivia is scheduled as a controlled substance. So being a controlled substance, there's additional restrictions that are imposed on it as a prescription drug. So I think while there's good effectiveness of those products, there's also some limitations associated with them that has led to it not taking off in the same way.
Okay, well, thanks for that insight.
Dr. Gilkey, I just wanted to
Yes.
add that with the Qsymia as well, the topiramate component of that drug has been associated with cleft palate. And so that's the biggest concern in terms of the birth defects, with the total body weight loss of Qsymia being around like 8%. It's not.
There's better alternatives.
Yeah, there's better alternatives and you don't want to
Yeah.
risk that. Yeah.
Okay, well, thanks, guys. Oh, I'd love to continue picking your brains, guys, but we've reached the end of our scheduled time. We've included resources for you at the end of this presentation. Thank you all for joining us, and thank you to our panelists for sharing actually Absolute wealth of useful information. I hope this hour will help you to successfully support your business. Just a reminder, we will be emailing you a survey right after our conference. Please be sure to give us your feedback so we can continue to provide relevant information. Our next session will be held on February 15th. Our topic will be mentorship and succession planning strategies. This is an area many businesses are very challenged by. I hope you will join us. We will send you the link for this session. We encourage you to share the invitation with your friends and colleagues. By working together to promote good health, we will be promoting good business. Have a great afternoon.